Welcome back to Core Anesthesia. Whether you are a student prepping for tests and boards or a CRNA here to earn CEUs, we are glad you've joined us. For more about us, make sure to check us out on Instagram at Core Anesthesia and online at coreanesthesia.com.
Welcome back to Core Anesthesia. I'm Cole here with Tanner, and today we want to do a discussion on cranial complications. And specifically, we're going to be talking about what are some different events that can happen with the brain that would require surgical intervention, and how are we, from an anesthetic standpoint, going to be doing things to take the best care of these patients. So topics we're going to be discussing is arterial venous malformations, intracranial masses. We're going to be talking about intracranial pressure. We're going to be talking about aneurysms. So to start, we're going to go through more of the vasculature in the intracranial space, and we're going to discuss aneurysms and the arterial venous malformations. And then we're going to move into the pressure of the brain and what causes pressure to go up, to go down, and include the intracranial masses in that section as well. So to start, we just want to do a very brief overview about the vasculature in terms of what blood supply that we have coming into the brain. So Tanner, do you just want to start us off with that?
So when we're talking about the vasculature here, the first thing we'll talk about is the circle of Willis. And later when we're talking about aneurysms, this is going to be, a really primary subject that we'll be talking about, this vasculature here. So it's important to think about, what is the circle of Willis comprised of? We have the vertebral arteries. You have the basilar artery that will form the posterior cerebral arteries. And then you have the internal carotid arteries that form the interior and middle cerebral arteries. And we're talking about cerebral blood flow. The brain gets about 15% of the cardiac output. So, in relativity to the rest of the body, obviously a very important body system. We're talking about the cerebral blood flow. Normally, the cerebral blood flow, or CBF, you'll a lot of times see it abbreviated as, is usually around 50 mils per 100 grams of brain tissue per minute. We want to make sure that this remains above 20 mils per 100 grams of tissue per minute. If there's, less than that 20 mils per 100 grams, then you have a risk there for ischemia. And so brain cells obviously need oxygen for the metabolic purposes to maintain their cellular function as well as the electrical activity. So the amount of oxygen needed is CMRO2. This is going to be a very common thing that we're looking at when we're talking about the oxygenation of the brain matter. And so this stands for the cerebral metabolic rate of oxygen, CMRO2. So under normal circumstances, the CMRO2 is around 3 to 4 mils of oxygen per 100 grams of tissue per minute. So when you think about this, breaking it down, cerebral blood flow, we talked about the main vasculature there with the circle of Willis. Now we're talking about the actual percent of the cardiac output, 15%, and then breaking that down even further, talking about the actual metabolic demand, the CMRO2. This is what we'll be talking about here when we're talking about mismatches and those types of things. So the higher the CMRO2, the more oxygen is needed by the brain. So that's going to require an increased cerebral blood flow. We know that your blood is going to be, the hemoglobin specifically, are going to be carrying oxygen to the different tissues. So it makes sense that if you have an increased CMRO2 or an increased metabolic demand, then you need that oxygen level to increase to match that. So areas of the brain that are more neuroactive will need more oxygen and will need more of that cerebral blood flow. So this is what we consider neurovascular coupling. As you need more metabolic demand because they're more neuroactive, then you need more oxygen. And so that cerebral blood flow will increase to meet that demand. On the flip side, we can also talk about decreased CMRO2. So what are the things that are going to decrease the metabolic demand? As you decrease body temp, you're going to decrease CMRO2 by 7% for every 1 degree Celsius. Many times in the ICU, we think about this specifically if you had someone that was a cardiac arrest and you're trying to cool them with like an Arctic sun or something like that. The purpose here is that as you decrease the body temp, you're going to decrease the CMRO2. And so that is going to theoretically preserve the brain tissue or give the brain tissue time to heal. And so you have opportunities here to also decrease the CMRO2 by doing things such as decreasing the body temp. Volatile anesthetics, except for nitrous oxide, and some actually intravenous anesthetics like propofol, will cause the CMRO2 also to decrease because you're going to have less electrical activity in the brain. Again, we should make the exception here. Nitrous oxide does not follow that rule. but we're talking about the other volatile anesthetics, and then especially propofol. We'll think about that when we're, as a very typical drug that we'd be giving in anesthesia. Those are going to decrease your CMRO2. I mentioned that nitrous oxide does not cause decreased cerebral metabolic rate of oxygen. It actually increases it. What are other things that we can see with that? Ketamine would be another one that would increase CMRO2. And then think about the opposite of if you have hypothermia causing decreased CMRO2, hyperthermia is going to increase it. Seizures will also increase it. I should mention that here just because you're going to have that more electrical activity.
So next we want to talk about cerebral blood flow, and Tanner briefly introduced this topic already, but I want to go in a little bit more depth here. So when we're talking about the actual blood flow into the cerebral space, what are some things that are going to alter that? And one of the main things is going to be your PaCO2, so your carbon dioxide levels in the plasma. And that causes vasodilation of the cerebral vessels. So the more CO2 you have, the higher the PaCO2, the more vasodilation that we're going to see with these vessels. And this continues up until around 80 or 90 millimeters of mercury of CO2, and then it kind of maxes out in terms of the vasodilation. On the opposite spectrum, we'll have vasoconstriction with lower PaCO2 levels, and this maxes out around 20 to 25 millimeters of mercury. So as a result, let's say you have a patient that has respiratory acidosis. So for respiratory acidosis, then you're going to have a higher PaCO2 level. So with a higher PaCO2 level, we're going to have vasodilation of the cerebral vessels, which will then increase that cerebral blood flow, because the more dilated we are, the more volume that can flow through those vessels. Secondly, I want to mention that cerebral blood flow, or CBF, changes by 1 millimeter per 100 grams of the tissue per minute for every 1 millimeter of mercury change in PaCO2. So if you want to calculate it out mathematically, if let's say you're doing an ABG in the middle of a case and your PaCO2 is 35, then you know that if you check it later and it's now 33, you're going to have changed it by 2 milliliters per 100 grams of brain tissue per minute in terms of the cerebral blood flow. Now, I mentioned respiratory acidosis will obviously be a big player in this. What about metabolic acidosis? Well, actually, metabolic acidosis does not affect the cerebral blood flow, and this is because only the PaCO2 levels affect cerebral blood flow. Why? And that's because the hydrogen ions and bicarb does not pass the blood-brain barrier. Only the CO2 levels do. So when you have a metabolically acidotic state for a patient, that change in the other values are not going to cross the blood-brain barrier, and we're not going to see dramatic change. The only time that you would is when you start to have a compensation of that PaCO2 later down the road. Other things that can alter your cerebral blood flow will be hypoxia, and this can cause, just simply hypoxia to the brain will cause vasodilation of the cerebral vessels. And this really occurs when the PaO2 levels get below 50 millimeters of mercury. And that makes sense. If the brain tissue is not getting enough oxygen, it's going to want to cause vasodilation of the cerebral vessels to try to increase the cerebral blood flow. And then lastly, cerebral blood flow is dependent on venous pressure as well. And what we mean by this is if you have a decrease in drainage from the head due to either, let's say, a backup in blood from the right side of the heart, you have maybe jugular compression, you have increased PEEP, anything such as positioning, maybe the neck is bent that way or flexed that way, that will prevent, again, that jugular compression, prevent the flow of blood to get out of the brain. This will cause a backup and a higher central venous pressure that will cause less blood to flow into the brain because we have blood backing up through the vasculature. So hopefully that makes sense that the venous side also plays a role. And we'll get into that a little bit more when we talk about cerebral perfusion pressure, how we calculate that not only by our map with how much blood flow is coming into the brain, but also with the CVP and how much is leaving as well.
So when we're talking next about cerebral aneurysms, most often these occur in the circle of Willis. I talked about that vasculature at the very beginning. The anterior communicating artery and the anterior cerebral artery are the most common sites that you'll see these aneurysms, usually asymptomatic and found, oddly enough, through screening with patients with a headache, or you have just a screening for some other reason and you can see these aneurysms. An aneurysm will develop based on the transmural pressure, which is calculated as the mean arterial pressure, so your MAP, minus your ICP, your intracranial pressure. So the difference there is what is going to cause this aneurysm to occur. So the map is going to be your pressure inside the cerebral vessel that's trying to push the walls of the vessel outwards. So, I mean, think about when you have, to make this like so simple and very basic, you have your heart beating blood. That blood is going to be going through your body. The map is going to be what we're thinking about, that mean arterial pressure that's inside the cerebral vasculature. So that's what's going to be pushing those walls outward. Your ICP is the pressure inside the brain that is pushing against the outside of the vessel, trying to push the vessel inwards. So this is typically in equilibrium. Where you have an aneurysm is a spot of weakening in the vessel wall. And so you're going to have that vessel wall pushing out like a balloon of that cerebral vessel. So the higher that you have a map, the more pressure that's going to be inside that aneurysm that is going to be pushing outward, and the increased risk there for rupture. So this makes sense that if you would have a really high blood pressure, really high map, and you have this weakening spot there in the vessel wall, that's where you're going to see that increased risk for rupture and increased risk for bleed. The ICP is going to be pushing back against the aneurysm and contain it. And so really you could look at it two ways. You have one, a risk if your map is really increased, or two, you have a risk for aneurysm rupture if your ICP decreases. So both sides of that coin are going to be affecting. Again, we're talking about the transmural pressure. That's the kind of push and pull between the map and the ICP. And either side of that coin can cause an issue there, a risk for rupture. For treatment of an aneurysm, we treat an aneurysm by clipping the aneurysm or placing a coil inside the aneurysm via endovascular coiling technique. For larger aneurysms, surgeons may place a stent to block the blood from getting there into the aneurysm and causing more blood flow that's going to be pushing, through that aneurysm pocket and risking rupture there. During the anesthetic for these cases, you want to keep the systolic between 120 and 150. You'll obviously be wanting to have this conversation with the surgeon during the case to make sure you're on the same page. Too high of a blood pressure will increase the risk for bleeding, but if you have too low of a blood pressure, then you get into a risk for vasospasm and also ischemia. We know that our bodies acclimate to different blood pressures. So say a patient is used to being at 180, we need to have that conversation with a surgeon about where you're going to keep your maps, because like I said, too low of a blood pressure, you're going to get into vasospasm, or you have the risk for vasospasm, I should say. But also, we also are always thinking about the ischemic picture there too. If the body is used to being perfused at 180, then decreasing that too much is going to potentially have some negative effects there. You want to limit increase in blood pressure during very stimulating parts of the anesthetics. So think about induction, or if you're going to be, using pins for the head, those are going to be very stimulating parts of the procedure. You need to be thinking ahead and preparing for those cases so that you don't have a surge in blood pressure and again, a risk there for rupture. If one of these vessels or aneurysms do rupture, then you can get a subarachnoid hemorrhage. So what are things that we would see with a subarachnoid hemorrhage? You can see a very bad headache, if it's before anesthesia, nausea, vomiting. You can have sensitivity to light. You can have an increase in ICP simply because that blood is filling into that CSF. It's going to limit the amount of CSF that can drain. And so there's going to be basically an obstructive hydrocephalus that's going to be causing that increased ICP. Depending on the amount of blood that is pooling in the brain, the patient may be obtunded or awake. It just depends basically how this is affecting them. But we really need to think about securing the airway. So you'll move on to a general anesthetic. You'll have neuromonitoring throughout this case. And again, like I said, you want to try to limit the amount of SNS stimulation. So you can use esmolol or labetalol or even remifentanil prior to induction. But with these really stimulating parts of the procedure, you want to make sure that you are using strategies to limit the amount of stimulation there and ultimately things that would increase the pressure and thereby increase the amount of bleed that's happening. We want to maintain the cerebral perfusion pressure throughout the procedure. So a MAP, you want to have close to 40 to 50 in order to maintain the cerebral perfusion pressure throughout the procedure. When we think about a MAP goal for these procedures, typically 40 to 50, a little bit lower of a MAP is helpful for the surgeon to be able to have control there and minimize the amount of bleeding that's happening. You want to communicate always these goals with the surgeon. So you need to talk about goals for CO2. Cole mentioned earlier about different things that are going to increase or decrease the amount of cerebral blood flow. So you want to talk to them about the CO2, what goals we have there, what goals we have for MAP, if there's any other medications that they are specifically wanting, if they want any steroid or if they're looking for mannitol or anything like that that would help them. Always have those conversations with the surgeon. Lastly, you want to have blood in the room and ready to infuse. These bleeds can become a bigger issue than simply the initial bleed very quickly. If they get into bleeding, we want to make sure that we have blood in the room and ready to transfuse.
So after an aneurysm rupture occurs, the patients are at risk for having a cerebral vasospasm. And this can occur typically 3 to 5 days after the initial rupture of the aneurysm. And the theory behind why this spasm happens is that it's initiated by the release of free oxyhemoglobin and the associated byproducts, along with calcium channel involvement. So we don't know exactly the mechanisms, but that's kind of the theory behind it. And what occurs is that you have this contraction of the cerebral arteries, which is going to then lead to ischemia of the cerebral tissue. So our goal to prevent this is to try to maintain cerebral perfusion pressure. And if a spasm occurs after that aneurysm rupture, we treat it with what's called triple H therapy. And so 3 H's here. The first is hypervolemia, the second is hemodilution, and the third is hypertension. So hypervolemia, and we want to increase the volume in order to increase the CVP greater than 10. Albumin is going to be preferred here, and then crystalloid. We're going to do hemodilution, and this is to get the hematocrit around 30%. And then lastly, hypertension. And we want to have about 20 to 30 millimeters of mercury greater systolically than the patient's baseline. So with this triple H therapy, we can do this to prevent the spasm and then ensure adequate hydration throughout to minimize now the risk of having this spasm occur. But again, this is also going to be a treatment as well. We oftentimes hear of giving a calcium channel blocker called nimodipine to be used to basically increase the collateral cerebral circulation. And it's injected into the area that's having the spasm. And what this will do is it can cause some hypotension. And so we need to potentially run a phenylephrine drip if you're intra-op when you give this medication, just to make sure you keep the systemic blood pressure elevated. But the purpose of it is to help with that vasospasm and ensure that we're getting adequate blood flow to the tissues on the distal side of that spasm. And the next we want to talk about arterial venous malformations. And what this is a congenital connection in the cerebral vasculature in which arteries flow directly into the veins. So instead of going through all the mesh of capillaries and switching from arterial side to venous side, we're basically just spilling artery into vein. And because of this, it's typically found at a younger age and a younger population than the aneurysms that are typically later in life when we see those occur. Signs and symptoms of this abnormal connection is going to be bleeding, seizures, even ischemic areas of the brain due to stealing blood from healthy brain tissue. And at these sites of the malformations, there's going to be a lack of ability to auto-regulate the cerebral blood flow. So when we talked about the PaCO2 levels in the brain and how that will cause either vasodilation or vasoconstriction, you're not going to have the ability to do that and auto-regulate the cerebral blood flow from this site of the malformation. And so when we treat this, the anesthetic plan is going to mirror very simply and closely to the cerebral aneurysm that Tanner just talked about. So basically, we're going to go through the same thing. We're not going to want to cause dramatic increases in blood pressure and stimulation. We want to keep the blood pressure at status quo, talk to the surgeon about what his preferences or her preferences are in terms of what your CO2 should be, what your blood pressure goals should be. But again, we want to really minimize any of that surgical stimulation. So just be mindful of the fact when they go to do pinning, or again, when you do your induction, just anything that might be very stimulating, we want to keep that at a minimum.
We've talked a lot about intracranial pressure. I think it's important that we stop and just make sure that we've clarified or defined what intracranial pressure typically looks like. So normally we see 5 to 15 millimeters of mercury. It's considered elevated if you're above 20. And the way we measure this is through an intraventricular catheter within the lateral ventricle. The transducer should be at the height of the ear. Remember, when we're doing a transducer for an A line, that's the phlebostatic axis. But for here, when we're doing the intracranial pressure, make sure that your transducer there is at the height of the ear. Signs and symptoms of increased ICP, you'll typically see someone complaining of a bad headache. You'll see nausea, vomiting. You can see focal neurologic deficits, altered consciousness. Sometimes they'll exhibit seizure activity. You can also see some altered breathing pattern as well. All things that would lead to a thought of having increased ICP. Another thing that we'll see with ICP is Cushing's triad. So remember, Cushing's triad is going to be the combination of the three things: hypertension, bradycardia, and then you'll also see irregular respirations as well. When we're talking about intracranial pressure, so intracranial, what are the things that are going to be making up the intracranial pressure? We have brain tissue, we have cerebral spinal fluid, CSF, and then you have the cerebral blood flow. So think about these three things when we're talking about here in a second about how we're going to be affecting the ICP. Here, just quickly, you can think about, okay, you have brain tissue, you're not going to be affecting that. You have your cerebral spinal fluid. There's ways that we can alter that. There's obviously side effects and different things that we need to take into account when altering cerebral spinal fluid. And then you have your cerebral blood flow. That's going to be most typically what we will alter when we're talking about an anesthetic and we're trying to affect the ICP. Cerebral blood flow is really the thing that we can alter the most efficiently. These three things are all physically limited due to the skeletal outline of the skull. So again, if we're trying to limit the pressure inside the skull under 20, remember 20 millimeters of mercury is what we're considering an elevated ICP, then like I said, one of those three things you have to alter or you have to change. If one thing is going up, then you need to try to affect the other things. Let's quickly talk about the different ways that we can have these three things be altered. So first of all, let's talk about the brain tissue. So brain tissue, if a tumor develops, that's typically what we're going to think about. Or if you have brain swelling, that's going to be an increase in the actual tissue mass. And that's going to cause an issue there with the increase in ICP. CSF is another thing that you can see. CSF is going to be created from the choroid plexus and it's broken down by the arachnoid villi. So if you have too much being produced or if you have a decrease in reabsorption, then you're going to have an increase in ICP. About 150 mils of CSF is in the brain at any given time. We typically make around 500 mils per day. So we're constantly doing this process of creating CSF from the choroid plexus. We're constantly absorbing it by the arachnoid villi. Again, this is a balancing act where both creation and absorption need to be happening, in tune so that you have that around 150 mils of CSF at any given time. This is another way that you can have alterations there in that intracranial matter that is causing the increase in ICP. Last thing, we already talked about this, but if you have an increase in your cerebral blood flow or bleeding, again, that's going to cause your ICP to increase as well. So as your ICP continues to rise, there's going to be more pressure that the cerebral blood flow is going to have to push against to get the blood into the cranium. So if you have a reduction in the cranial blood flow, this could potentially cause ischemia to the brain. If you have ischemia to the brain, that causes edema, which is going to only further increase the ICP, which is only going to further increase the pressure that the blood flow needs to push against, which is, again, going to just continue to cause this mismatch, leading to ischemia, leading to more edema. And then you have, as you can see, this downward spiral. So it's really, really important that we have an idea of the different things that we can manipulate and the different things that we need to do. We're paying attention to the signs and symptoms of increased ICP, but also understanding, okay, what's going on here? What's driving the issue for increased ICP, and how can we get ahead of this before it has that downward spiral? Herniation of the brain can ultimately occur with an increase in ICP and with decreased cerebral blood flow. And so again, these are all things that you're trying to keep in mind and keep in balance as you are managing ICP.
So in terms of the ICP management, in order to reduce ICP, we can do a couple of different things. We can reduce the amount of cerebrospinal fluid, the CSF. We can reduce the edema on the brain. We can, obviously, in a tumor type state, we will reduce the tissue mass, or we will also evacuate any blood from a hemorrhage. So what are some interventions during the anesthetic that we can do here? So we can hyperventilate the patient, and this will decrease the cerebral blood flow. Remember, we talked about how if we decrease the PaCO2 levels, then that will cause vasoconstriction in the cerebral vasculature, which will then decrease the amount of blood flow coming into the brain and decrease intracranial pressure. If excessive hyperventilation does occur and we drop the PaCO2 below 30, cerebral vasculature constriction will occur to the point where we're causing potential ischemia to the tissues. And that ischemia to the brain tissue, the cerebral tissue, can cause edema then and swelling on the brain. So actually will work in the opposite direction for us. Keep in mind that our end-tidal CO2 is not the same as our PaCO2. So we need to be checking ABGs, arterial blood samples, to ensure and kind of get a trend. I like to do at the beginning of a case, figure out based on my ABG, how does that compare with my current end-tidal? My end-tidal might be 28 and my PaCO2 will come back to 35 millimeters of mercury. So just know that we're not talking about end-tidal here, we're talking about the actual PaCO2. Other things that we can do to help reduce ICP is going to be using Decadron, Solumedrol to reduce the cerebral edema. But we need to be mindful about what their blood glucose levels are, because any type of hyperglycemia that can develop is then converted into lactic acidosis and will cause more ischemia at that brain site, which would then cause more edema. So again, be mindful of what their current blood glucose levels are when you're giving these type of steroids. We can also reduce the CMRO2. As Tanner talked about before, we can reduce this with volatile anesthetics, propofol, and this will reduce and decrease the cerebral blood flow. So basically, then we're not going to need as much oxygen on the brain. We have less electrical activity, which will then decrease the demand of oxygen on the brain and then decrease the cerebral blood flow. And this eventually then will decrease the edema because we have a reduction in the ischemic levels. If the brain doesn't need as much oxygen, it's not going to be in as much ischemic demand, so we're going to have less edema. Tanner mentioned earlier, we can also do hypothermia down to about 35 or 36 degrees Celsius, and this will reduce that CMRO2 that I just talked about, and that will decrease the cerebral blood flow. Oftentimes, the surgeon will have you give a diuretic such as mannitol or Lasix, and this can be used to pull water across the blood-brain barrier due to increasing the serum osmolarity from giving these diuretics. We can also give hypertonic 3% saline, and this causes the same effect. We can run this as a drip, we can give a bolus, but just be mindful of the fact that we need to monitor their sodium and chloride labs if you're giving this 3% hypertonic saline. We can also use an external ventricular drain to drain the cerebrospinal fluid, and we would drain this at about 10 milliliters an hour. And additionally, we should be mindful during these cases to avoid cerebral vasodilators such as nitroglycerin, nitroprusside, that'd be doing the opposite of what we'd be wanting in this case. And then lastly, we need to limit the use of PEEP so that more venous outflow is then going to occur. Because remember, I talked about earlier, if we're obstructing any of that venous outflow, it's going to cause a backflow of blood into the brain and increase that pressure. So we need to make sure that their head position is neutral. We're not causing any type of jugular obstruction that's going to prevent any of that blood flow from leaving the brain. So we can sit the patient up even 30 degrees if possible, and this will ensure that venous drainage. And again, this is depending on the surgery and what the surgeon wants to do with positioning. But if possible, we like to sit them up a little bit.
All right, the last topic that we want to cover in this section is traumatic brain injuries. And we want to talk about, first of all, what this will look like as it presents to the hospital. And secondly, we want to talk about, okay, how are we going to manage these patients undergoing anesthesia? So typically, when you're thinking about a TBI, the significance of the head injury is going to really depend on how much irreversible damage you have from the actual initial trauma, but then you also have secondary insults. So you have things like hypoxemia, hypotension, you have cerebral hematomas, you can have sustained intracranial hypertension. These are all things that can come secondary to the initial trauma. So when we have a surgical and really anesthetic intervention, we're trying to really limit any of these secondary insults that could potentially happen. When you often see these patients when they come to the hospital, many times they're already going to be intubated, mechanically ventilated. If they're not, you're going to want to have a very brief but thorough neurologic exam. It should be also, obviously paying attention to the patency of the airway. And then you're also going to be wanting to look at hemodynamic stability. So if you have any hypotension or anything like that, you're going to try to manage that as best you can. Up to 70% of the patients that have these head injuries are going to have some level of hypoxemia. Either if you have fat emboli, you can have neurogenic pulmonary edema, or you can have a pulmonary contusion. Up to 70% is going to have some level of hypoxemia. So it's important that when we look at these patients, you're going to, again, the neuro exam is going to be very important if they're not already intubated and mechanically ventilated. But while that's happening, you need to be paying attention to securing an airway if that's appropriate. Patients who are hypoventilating, or if they don't have a gag reflex, or if they have a GCS score of 7 or below, you're going to want to immediately intubate them. Something that's important to keep in mind when you're intubating these patients, unless they're ruled out by radiology, the patients are going to be assumed to have cervical spine injury. So you're going to want to maintain neutral neck position while you're intubating. Glide scope intubation is going to be preferred in this case over DL. And you're also going to want to remember that we are not doing nasal intubations because of the risk there for possible basilar skull fracture. And so you want to avoid nasal intubations and then also keep that neck as neutral as possible, keeping in mind they may have a cervical spine injury. In these cases, RSI, rapid sequence intubation, should be performed. Sucks is controversial because you want to theoretically avoid sucks because the risk of further hyperkalemia if they have, already altered electrolytes. And you could also see increased ICP. So the reason I say that's a little controversial is because in this case, you're trying to gain a patent airway as quickly as possible, as effectively as possible. And so really you have to judge the pros and cons here of what are the risks for giving sucks and what are the benefits for getting an immediate airway. What really should be considered per the literature is that you would consider a rapid sequence induction with rocuronium, giving 1.2 milligrams per kilogram to perform your rapid sequence induction. I mentioned earlier that you're going to want to pay attention to the patient's hemodynamics. Obviously, you're going to be trying to manage what you can there. When you're treating hypotension, it's important to remember that you're going to want to treat that hypotension with isotonic fluids. If you are giving hypotonic solutions, remember that the hypotonic solutions will decrease serum osmolarity. This is only going to increase the cerebral edema, which is going to increase the ICP, which is going to be counterproductive for what we're trying to do. You're trying to maintain cerebral perfusion pressure at about 60. And remember, when we're talking about cerebral perfusion, we're talking about, in this case, adjusting the map to improve that cerebral perfusion pressure. You're going to also want to be looking at their coagulation and look at their different labs to see if there are anything that we can intervene to try to minimize the risk of bleeding in the brain. So if you are looking at their different lab values and you see anything that we can, address, that's something that we would want to do. Remember that severe brain injury can cause a dramatic release of tissue thromboplastin and activation of the complement system. What this is going to cause is basically a DIC picture, a disseminated intravascular coagulopathy and fibrinolysis. So this is where you can really have insult to injury when you have these very severe brain injuries. Things that we need to also pay attention to, I mentioned we're looking at labs, but you should also be looking at home medications and many of these things will show on the different labs that you are drawing, but also quickly, you should be paying attention to their home medications. If the patient is on warfarin, then you may need to give FFP, fresh frozen plasma, to emergently reverse the warfarin. Vitamin K should also be given as well. And so, like I said at the very beginning of this, we're talking about primary injury and then the secondary issues that can happen throughout the case with surgical intervention and anesthetic intervention. These are all things that we're trying to minimize. A certain amount of damage potentially has already been done. What are we able to do that is going to limit further injury or further complications? So specifically here, we're talking about the TBI. We're looking at, okay, well, what can we do as far as decreasing the risk for bleed? What can we do as far as fixing, hemodynamic instability? How can we help decrease the amount of ischemia related to oxygen demands and maintaining a patent airway? All these things are going to be, different strategies that we're trying to employ simultaneously to care for the patient. While we're performing anesthesia, it's important to prevent further increases in ICP. And so we already talked about different ways that we can manipulate ICP and the things that create our ICP. Remember, that's going to be your brain mass, your CSF, and then also your cerebral blood flow. And so as we're thinking about, okay, what are the things that we can manipulate? Remember, those are the three things that we're trying to adjust to prevent further increased ICP. You're going to want to have arterial and central venous monitoring during the surgical procedure. Do not wait for these lines to be placed if the patient is requiring immediate surgical decompression. You're not wanting to wait for these different monitoring modalities before you would do emergent decompression. Obviously, that's going to be the most important thing to prevent further injury, but it is important that you're able to get an A-line, that you're able to check central venous pressures as you move throughout these procedures. Cole mentioned previously different things that we can do to manage ICP. And one of those things was hyperventilating the patient to lower the ICP. In this scenario where we have a traumatic brain injury, using hyperventilation to lower ICP to basically cause that vasoconstriction in response to a lower PaCO2 is actually not recommended for these patients. So something to keep in mind there, specifically as you're managing these patients. During your anesthetic, you're going to want to maintain your MAC levels of all anesthetics less than 1 MAC. Typically, these patients are going to remain intubated after the procedure to, again, limit the risk of these secondary events occurring. And so typically sedation and paralysis is going to be continued there to the ICU. But it's important, again, that you remember for sedation levels, those volatile anesthetics, keep them under 1 MAC. And then also just create a plan there as you're thinking about transitioning them to the ICU, communicating with your surgeon goals there for ventilation and then sedation as you're trying to, keep the whole picture there in mind. Hopefully today's episode is helpful as you think through. At the very beginning, we talk about the anatomy and where we potentially may see aneurysms, what, the cause and effect is of those, how we're going to manage those through anesthetics. Also the different types of things that we'll see with increased ICP, how we're going to manage that. And then here finally, as we talk through traumatic brain injuries and management of that. I know for me personally, neuro is one of those topics or scenarios that whenever, I see that on the schedule or I see that coming in on a call shift, you get a little, kind of flutter in your chest because you're nervous about all the different things that can go along with it. And it really is true. There's so many different avenues of symptoms and side effects and these secondary effects that you can see. But hopefully this is a good reminder of all the different ways that we can be monitoring these patients and evaluating these patients and caring for them to maintain safety as we go through our anesthetics.